Good morning, everybody. It's good to be here after being diverted to 2 states back and then forwards. So my talk is endovenous ablation, but I think I'm going to change that to endovenous treatment as opposed to ablations. These are my disclosures. And in 2022, really, I don't have to tell you that ablation means basically destroying the vein one way or the other. In the old days, the traditional model right in between, right in the middle of that palette is the surgeries, whether it is excisions or ligations to the right or to the left, or the thermal ablations, radiofrequency ablation that was approved in 1998 and laser in 2001, so we're over 20 plus years now. Since these technologies have been available, now multiple companies are making these, so again, it's difficult to go through each one of these technologies. I want to rather talk about the disease state and patient management than the techniques themselves. More recently, we have the non-thermals, which are the microfoam Varithena, which is available only in the United States. Glue, cyanoacrylate glue, available in the United States as Venous Seal, and there are others in the other countries. And then there is mechanical chemical ablation also, where it's a combination of sclerotherapy and somewhat of irritation of the endothelium. So in regards to which technique is superior to the other, again, there are multiple studies out there. Whether they are large registries or randomized trials that are small, you can nitpick at which technique is good depending on which vantage point you look at through, but ultimately, they're all the same in terms of overall treatment efficacy. We ultimately need to know how the patients do. Patient-reported outcomes are more important than the technique itself. So with that, I'm going to move on to patient preference. Patients don't know. Patients really don't know what they want. They're looking up to us to tell them what is best for them. So really, if you have a milder form of venous insufficiency, we use this simple map called the cartogram, where we basically have, does this work? I think the laser works. So where you have, if you start at the vena cava on the top, iliacs down, and then the central lines are the deep venous system, and you'll see the great saphenous vein joining at the groins bilaterally and small saphenous veins. And let's just assume that this particular patient has right great saphenous vein reflux and left small saphenous vein reflux, and probably has some symptoms or maybe wants cosmetic treatment. With this, you can use really any technology: thermal, cyanoacrylate, MOCA, microfoam, or simply compression therapy, and ask the patient to come back later. So again, any is fine in this setting. So just to clarify, other than microfoam, which will track through neovascularized tortuous veins, every other technology, RFA, laser, cyanoacrylate, or mechanical chemical ablation, will require a straight vein because they are catheter-based and you have to pass a catheter through them, and these are pretty stiff catheters. Okay, you've taken care of the straight veins. What about the other veins that the patients care about? Because you probably heard of patients who tell you that someone ablated their vein, but their vein on the outside of the thigh is still there, and it did nothing for it. So what about tributary veins, reticular veins, spider veins? Obviously, the first line of treatment is sclerotherapy, whether it's foam, liquid, using ultrasound, or not. So you can use those in conjunction with the ablative therapies for the larger straight veins. Or maybe there is no straight vein reflux and patients simply want this lateral subdermal plexus or spider veins treated, and you just simply need to do cosmetic sclerotherapy for these folks. So, or maybe there is a vein, skin over a vein that is unroofed, and the patient bled, and it looks like a murder scene when they wake up in the morning. And that is probably connected to a great saphenous vein, refluxing tributary straight to that vein. So obviously, you have to take care of the great saphenous vein and do some foam sclerotherapy to kill that other vein. So that's simple. Again, let's look at this particular patient. 2 legs, 2 different manifestations, both GSV reflux, right side, smaller veins, left side, huge veins. So if you look at the left side, if you inject foam into that, those veins will clot, they will become phlebetic and very, very painful. In those patients, you want to do phlebectomy, where you're basically mapping the veins out, injecting tumescence, and pulling the vein out. We described in addition to it, this is called foam-assisted phlebectomy, where you actually inject foam into these veins and then use ultrasound very precisely to make incisions, and then you can see the hook go in, grab the vein precisely, and the vein comes out, and it's almost a bloodless operation because you have foam spasming the vein from inside and then tumescence from the outside. If the veins are super large, obviously, call our vascular surgery colleagues, which we do. If the veins are super subdermal, you don't want to do any of these other minimally invasive technologies because those will result in a thickening of the skin. I don't know how this forwarded, but I saw this patient yesterday, so I thought I'll put it in yesterday morning at 10 o'clock. This is going on its own, guys. Okay. So this patient was sent to me because he had a venous insufficiency study before seeing me, left leg swollen. Sorry. I'm not touching anything. It's just going. Okay. So the left leg is larger, saphenous vein is refluxing. When I look at the vein map, it's like a chip shot. You know, it's been 10 years since I saw a patient like this. Let me go take care of it. I go into the patient has, come on, sorry. Wow. I'm sorry? Oh, next slide. Okay, got it. Okay. I didn't say next slide. Can we go back, please? Okay. So, sorry about this. But it's okay. We'll move on. So you see 2 knee operations on the right side, 1 knee operation on the left side. He had Achilles repair on the left side. And then, next please. I look at the echocardiogram. This gentleman had an echocardiogram in April, and look at the right ventricular systolic pressure, 70 to 75. So I simply tell him that he is not a candidate for any procedures. Can you move to the next slide, please? So treat the patient is what I learned, not the vein. Move on to the next one. Because whatever I do to this patient, next one, please. We keep clicking, please. So it's not just reflux. Yes, sir. It's not just, they don't trust me with that. Superficial reflux, next, please. It's perforator reflux, deep vein reflux, next one, and next, and stop there, please. So it's iliocaval obstruction, deep vein obstruction in the thigh, or elevated central venous pressure. So we have to think about all of these, right? Next, please. Apart from these, next, and next, stop there. Apart from the cardiovascular medical issues and medications that we talk about, obesity, limited mobility, stiffness that we talked about, and dependency, this is all challenging in this patient population. So it's not simply put a catheter and seal that vein shut, because the patient ultimately will not get the desired outcome that he or she or they are expecting. Next, please. So what are some areas that there is deficiency of evidence, controversy, or total vacuum? Let's look at those. Next, please. For example, all of us do foam sclerotherapy in conjunction with saphenous vein treatments in the plexus of the wound, right under the wound, with foam sclerotherapy, but specifically testing this hypothesis, to my knowledge, there's not much out there other than the Everett trial that used foam sclerotherapy for the majority of their ulcers. Next, please. But we all use it. Most of us do who take care of ulcers. Now, perforator ablation is also quite controversial. There are two different techniques, radiofrequency and laser. My choice here is laser for perforators, but my choice for ablations is radiofrequency because it's simple, it's consistent, and it's very few exchanges of wires. So in perforator ablation, they have to be carefully selected. The diameter needs to be over 3.5 centimeters. The reflux should be over 500 milliseconds, and it should be high volume in close proximity to a pathologic skin lesion. This is slightly overused, despite me having very high volume of severe venous patients. I still use very little of perforator ablations. Next, please. One other thing we all talk about who do this routinely is the presence of saphenofemoral junction reflux. So if you look at DEF, they all have saphenofemoral junctional reflux, and these are what are tested. Thank you so much, appreciate it. These are what tested, how late am I? Pretty late? 4 minutes, sorry. So if the saphenous veins are not refluxing, meaning the junction is not refluxing, we still treat them. So let me quickly go over to the staged treatments. The other controversy is, should we treat all the varicosities at the same time along with the ablation or not? There's probably lower intervention rate with concomitant phlebectomy. So let me skip over this. Mixed etiologies, I just showed you mechanical issues, but you could have phlebolymphedema, lipedema, phlebolipedema, phlebolipolipedema, lymphedema, and elevated heart pressures too, which then you have to carefully tease out which one is causing the most of the edema. Finally, we do have enormous choices of endovenous treatments. Treating the patient is important, setting clear expectations is important, deep venous obstruction consideration is super important. I try to go less invasive to more invasive because the word chronic is in the term chronic venous insufficiency. It's not acute, so we have time. Superficial venous interventions remain more of an art than science. Thank you. I'm so sorry about the technical issues. Thank you very much. Next is Dr. Razavi, my friend, interventions in chronic deep vein thrombosis, and hope this works great for you, Mahmoud.
Thank you very much. Great to be here. All right, so let's go to the talk here. So these are my disclosures. And so we're going to be talking specifically deep veins of the lower extremities, which is, a small part of a venous disease. We're not going to talk about superficial disease, which just Raghu just did. Dialysis-related stuff, mesenteric and splanchnic venous disease, which is a whole new world unto itself, cerebral disease, pediatrics, so on and so forth. So we're just going to talk about deep venous disease in the legs. So what constitutes chronic? Obviously, everybody agrees clot in the first couple of weeks would be acute, and anything more than 3 months would be chronic, and that's where we're going to concentrate today. Somewhere in the middle is late presenting, and then subacute. The reason I say that late presenting, because acute DVT patients in our practice, we actually treat them up to about 4 weeks or so. Your efficacy drops somewhat, but they're still treatable. We're going to be focused only on the chronics on the other end. So now, indications for deep venous interventions, there has to be a symptom. So there are a lot of asymptomatic obstructions. They don't need to be treated. And there's a various, iliac vein compression, central venous obstruction, chronic venous insufficiency, so on and so forth. Now, what constitutes obstruction? Really, it's not well known. Pressure gradient of 2 to 3 millimeter has been talked about a lot, probably physiologically significant. The problem is measuring that in a recumbent patient is going to be very difficult. The presence of collaterals, very unreliable. 50% reduction, everybody talks about. Never validated, probably wrong. And remember that in recombinant position, as I mentioned to you, you won't be able to measure it accurately. Collaterals unreliable, threshold not validated, and so we really don't have a good way to know what is a physiologically significant obstruction. But let's just go with the word obstruction. Now, so chronic venous disease in the FEMPOP segment, there is not much new. There is no good interventional options once those deep veins become diseased, whether it's reflux or obstruction or occlusion. Now, Access PTS showed some promising results, really not confirmed that we can reduce a patient's post-thrombotic syndrome by deep venous interventions in the FEMPOPs that are included. Maybe there is, not proven yet. In the iliofemoral segment, it's actually much better. The technique, the technical success rate of recanalization is improving. Dedicated venous stents are now available, and outcome variables are better understood, but nowhere close to the arterial side. Now, this is the summary of the data of the dedicated venous stent and the trials. As you can see, up at the top, I wrote the results of a meta-analysis, and that was most of those were Wallace stents. So that can be considered an outcome for Wallace stents. And then the Virtus, Vivo, Vernacular, and Abre, the 1 year, 2 year, and 3 year, and then on the two columns on the right side of the freedom from CDTLR and at 1 and 3 years. Results are fairly similar, and if you look at the non-thrombotics, the 1 year on the left side, results are spectacularly good. They're all 95% plus patency. So in that patient population, results are very good, and in the chronic post-thrombotics also, results have shown stents have shown very good results, recanalization. Now, the subject was in this, in the case presentation. So I'm going to do the rest of the discussion based on this case here. 74-year-old male, worsening bilateral edema, pain times 8 months, IVC filter placed 15 months ago, and then ultrasound showed occluded iliacs. And patient has started an anticoagulation with private MD, and recanalization and catheter rectal lysis was attempted elsewhere and failed. So the patient was referred to us at some time down the road, and the initial angiogram, we like to, in these patients, get low access so you have enough room, especially patients with chronic disease, to stent into inflow if you need to, which would be profunda. So can you play those videos for me, please? I don't have a means to do that. Both of them are videos. And it shows basically that here we go. You can see the occlusion on the right side, the common femoral is occluded, and on the left side, similar picture if they play the video. There you go. Now, I'm not going to get much into technical aspects of this and how this is done. Suffice it to say that not different than CTOs any place. The success rate in these are highly dependent on the experience of the center. Dabbling in it is okay, but if you have patients like these, make sure if you can't do them, just refer them to somebody else, because these are eminently treatable. So this was recanalized on that side, and then we got through the IVC up at the top. I spare you the details. Can you play that video for me? And then when you recanalize the contralateral side, what you want to do, make sure that, now in this case, here's the wire going up and going in the right direction, and you take it, and I usually use a stiff, straight glide wire for these situations. Any directionality should come from your catheter and not necessarily your wire. Now, remember in a chronically occluded IVC, even iliacs, there are multiple channels, and if you're coming from two sides, it's quite possible that you may end up in two different channels. So we use this technique of angioplasty, and then can you play the video, please? Is to make sure that you end up in the same channel from both sides. So you can see they're clearly in two different channels right there, going down the iliac. So you just have to redirect, bring the catheter up, as you can see right here in a second coming up. There you go. And that's a directional catheter. Pull your wire back in, and then boom, you're back in the same. So Once that's done, then we take the filter out. Obviously, that is not going to take the filter out. You have to adjust it, and now it's a more appropriate orientation. And the filter is taken out, and you can see IVC underneath it is occluded. Now you stent them. Can you play those videos? Yeah. And the other one. So your angioplasty and the stent video on the right side. Thank you. Now, let's talk about techniques of stenting. There are different ways you can use to stent these. I do not, in this case, we used double-barreled cable. I don't use that anymore. The middle technique or configuration is what we actually use in most of these. And you may say, well, then that may leave a skip segment of the IVC or the iliacs. And that's okay. This has been tested by a study of our colleagues in Aachen, that they looked at this and they showed that when they leave skip stents like this, the outcomes really don't actually make much of a difference, and they're very similar to continuous stenting. So now what is new? A novel hypothesis, and that is, well, how do we prevent rethrombosis in acute setting? In acute setting, how do we prevent post-thrombotic syndrome, which is up to 40% in acute DVT? And how do we prevent those 20 or 30% thrombosis rate or re-occlusion in the stents? So that the idea of inflammation in the venous segments and anticoagulation has been around for a long time. So this being now tested in 2 studies, the dexterity trials, one in an acute setting, the other one in the chronic setting, of injecting dexamethasone after the intervention into the vessel wall and see what happens. The preliminary results actually look very promising, that this technique may actually reduce post-thrombotic syndrome and reduce venous thrombosis rate in patients who are stented. So in conclusion, deep venous intervention should be performed in symptomatic obstructive lesion, and I just want to say symptomatic again, and rigorous prospective studies support the use of stents in the iliocable and iliofemoral segments. Thank you very much.
All right, thank you, Dr. Razavi. Next, we're going to welcome to the podium Karam Harth. She's going to talk to us about May-THURNER syndrome. Are we over-treating?
Good morning. Thank you so much for the invitation. Let's see if I can do this correctly. Maybe this way. There we go. All right, these are my disclosures. So in thinking about this question and this topic, I had 4 things to kind of think about to guide the conversation. So I want to make sure we're describing the same group of patients. So what are we defining as May-THURNER syndrome? What encompasses treatment for these patients? Are we following current appropriateness for use guidelines? And what is the role of new technology in the treatment of these patients? So let's start with the first one. So I think typically when people think of May-THURNER syndrome, they think of what's classically described as a focal compression on the left common iliac vein by the right common iliac artery, also described as a nivel lesion or non-thrombotic iliac vein lesion. The presentation is quite broad, and mostly the majority of patients are asymptomatic. Unilateral edema and pain, and sometimes venous claudication can certainly be a presenting symptom. And in other extremes, in the thrombotic portion of the case presentations, they can present with acute DVT. The definition is based on a focal compression when you think about the anatomy, and arbitrarily, as been described already by our other speakers, it's described as a greater than 50% diameter decrease, and particularly this is thought to be best measured on IVUS imaging. Now this is transposed from arterial definition with really no validation. If we think about these 2 systems, I mean, they're completely different. Arterial is a high pressure, high velocity, low volume, high resistance system, where the venous system is a low pressure, low velocity, large volume, and low resistance system. So this definition, although broadly used and widely used, still needs validation. But May-THURNER is more than just this greater than 50% radiologic lesion. So this comes into the question of what is a physiologically relevant lesion. And I think for a lesion to be clinically relevant, again, as we have been describing, so we're all on the same page, this is great, is what contributes to venous hypertension. So we got to think about all of the different levels. First, we think about the inflow. So the pore is their pore calf pump function. This relates to the volume flow at rest and at exercise. Is it positional? What are the differences between a supine and upright and a patient who's an elevated leg? Patients with primary valvular dysfunction. Obstructive processes at multiple levels, the location of this obstruction, the percent narrowing, the length of the lesion. Are there development of collaterals to compensate and allow this patient to deal with the obstruction? Intra-abdominal pressures and right atrial pressures. And so really a lot of validation is still needed to decide or to understand what degree of venous outflow stenosis is hemodynamically or clinically significant. And so again, thinking about when we are talking about this group of May-THURNER patients, there was a study looking at this radiologic finding. So they looked at 300 retrospective CT scans and also correlated their, by chart review, what their clinical symptoms were. On average, they found that a left common iliac compression was noted to be about 30% in men and 49% stenosis in women. When they broke it down by greater than 50 and greater than 70% stenosis, about 45% of the patients had left-sided common iliac vein stenosis greater than 50%, and 20% were at greater than 70%. This is 65% of the reviewed CT scans were noted to have a left-sided greater than 50% stenosis among the 300 scans reviewed. And when they looked at if there was any correlation between pain, edema, varicose veins, or venous claudication, there was no correlation with any of those symptoms to the percent stenosis. So I think for me is if you look for it, you shall find it, but it does not mean you treat it, nor that it is clinically relevant. So something just really important to look at, as I think we all have a lot of imaging to review. So what encompasses treatment for these patients? Well, treatment should really be guided by the presentation and the symptoms. So if a patient is asymptomatic, well, there's not much to offer. There's not much to gain from any kind of intervention. And then you have to think about the symptomatic patient. And then within this group, there's a range of symptoms. So it's not just a single type of presentation. So you have to consider that. The treatments, you should always consider your first mode of treatments, medical treatment, and also then beyond that, for the more severe patients, what are the endovenous therapies available? With regards to medical therapies, just some basic things like compression, ambulation, elevation, looking at their overall cardiac function and all those other factors we talked about that contribute to venous hypertension. And then, of course, anticoagulants if needed based on clinical indication. These are mostly for the thrombotic patients. And in regards to endovenous therapies, I think we're all here wondering about stents, obviously, because we're talking about a May-THURNER lesion. So in terms of following, the next question is, what are the current appropriateness for use guidelines? And I think for this, we really have to look to the literature. I think we really need to be guided by what's currently available. And so this is a great review paper from May of 2020 by a consensus of multiple societies that have really looked deep into the literature. And when we look at iliac vein or IVC stenting, really patients with advanced SEEP classification or patients with LDS, healed ulcers, or active ulcers, there's enough data to say that, well, if this is the clinical scenario, then iliac or venous stenting, if the lesion is present and you think it's hemodynamically significant, is appropriate to treat. Anything beyond or less than that is really not, does not have great evidence, particularly the C3 patient with edema. And I think here, for me, this is really where I think most of us would think, well, this is the May-THURNER patient, the non-obstructive patient. Patients with C1 or C2 disease or lower classification disease, it is never appropriate to pursue a venous stenting. So looking at this closely, I think if you break down from C1 to C6, you got to wonder, is there a May-THURNER lesion? Again, non-thrombotic patient. We don't know what percentage of these patients across the various groups may have a symptomatic or an asymptomatic May-THURNER lesion compression. And this is that C3 classification group where I think there's the most controversy. And for me, when I'm speaking with someone or someone's asking me about a May-THURNER patient, I think most of the time this is the group they're talking about, not the thrombotic or the post-thrombotic patient. And I think what's important to consider, which is also noted in this article, is that we have really good data to treat patients between class C2 and greater in the axial system. And that should probably, and there's more appropriate data for that, and that should definitely be sort of the first mode of thought when you're working up someone with edema. So looking at long-term, another study looked at the long-term complete relief of swelling in patients with NIVL, non-obstructive iliac vein lesions, as a subgroup following outflow stenting. And at 5 years, really only 24% remained with edema-free. They still had some benefit at 5 years with pain improvement, but the edema itself was not a persistent improvement in these patients. And in general, about 50% or less of these patients with edema alone are thought to benefit from venous stenting. So are we overtreating? Are these patients really appropriate for this therapy? And so to me, this moves on to the technology. So I think in 2019, we were all very excited. There was endovenous stenting finally came through, FDA approval for dedicated venous stents. So the first one to market was Vici from Boston Scientific, followed by Venovo from Bard. And this brought about a sense of enthusiasm and excitement that we finally had really great technology for these patients. Well, not too long after, in January of 2021, the first safety notice came about from some deployment issues, and about 3 months later, the first recall occurred. And I think this really struck a chord with folks who use venous stents because it brought pause to what we were doing. Do we really understand how good is this technology? What is the long-term effect in these patients? Most of these patients are young and of working age, so the implications of placing a venous stent is significant. So 2 stents were then recalled within a 1-month period. And as far as it was publicly disclosed and as far as we could tell, most of these were related to stent migrations and leading to cardiac embolization, and mostly among the patients with non-obstructive iliac vein lesions due to under or poor sizing of the stent relative to the vein and the location of the vein where stent was placed, and lack of IVUS guidance or experience. So to me, when a new technology comes about, I wonder, well, what are the trends? Who are the users? What are we using it for? Who are the patients we're offering this to, and what is the appropriateness of that indication? So just some market trends, which was recently shared by Dr. Meisner, which was very interesting to me, that there was a 9% predicted growth in 2020 of the use of venous stents. And again, we said this was around just shortly after they were approved. And it's thought that the usage of venous stents will have an annual growth rate through 2027 of about 8% per year. So that's not a small growth rate. Well, to me, again, who are we treating? So I'll just share some early data that we're doing, looking at a database of multiple large healthcare organizations across the United States. It's a retrospective study, a chart review. We've identified 6,528 patients who've undergone endovenous stenting. And this is based on their CPT code, and this is from the years of 2014 to 12 of 2021, so way before the FDA approval and into this era of endovenous stenting. We evaluated demographics, trends over time, trends based on diagnosis codes at the time of venous stent placement as well, and various other factors. So what we found just preliminarily as an early kind of view into this data, it's mostly white men, which is not what we typically think of. So this brings into question access to care. The categorization, when we looked at the categorization, we grouped these patients based on the indication at the time of endovenous stenting, and this is based on the ICD code. I thought this was quite interesting. So about 30% of patients had an indication of acute DVT, 17% for chronic DVT, a vein compression with no other associated thrombotic event, 72%. And patients with pelvic congestion comprise 6% of this population as well. So vein compression was the single largest diagnosis noted at the time of venous stenting. This remained the highest independent, the highest code, despite the over time evaluation on FDA recalls. And it's unclear what the SEEP scores or what the clinical indications, let's say there's an ulcer or edema, what the underlying SEEP score is for these patients under the vein compression. But they still remain the largest group across the time periods. And where you see the arrows is we have an increase in general of use of stents among the groups of acute DVT, chronic DVT, and pelvic congestion, despite the FDA recalls. So I think when we have this question of are we overtreating May-THURNER syndrome, we have to make sure that we're talking about the right patient group, and I think it's these NIVL patients with C3 disease. I think we still need better criteria to guide what we do, who we place the stents in. We need to understand the significance of the hemodynamically significant lesion, what would optimize patient selection, and the appropriateness of stenting amongst these groups of patients. Thank you very much. Okay,
We will skip a panel discussion after this, but next talk is interventions in acute deep vein thrombosis, Dr. Anaran.
Thank you very much, and I'm just going to go back, and I know there was a little change in the title of the talk that I think that wasn't reflected. So good morning, everybody. It's a privilege at the invitation to present here at this wonderful meeting, and this is a case that I'd like to present to you. It is going to be controversial. There are a lot of gaps in data, and by the end of my presentation, I promise that at least some of you will want to strangle me. Here are my disclosures. So, a 34-year-old fit and healthy naval engineer came to see me for a second opinion. He had actually developed varicose veins at age 19 in both legs. At first, no big bother, but they gradually began to become a little sore. He got thrombophlebitis. He had no history of trauma, no history of venous thromboembolism. And by age 21, the military hospital thermally ablated both his great saphenous veins and did some phlebectomies. It worked for a while, but then they came back. He got sore again, and by age 23, he had probably an additional ablation and further phlebectomies. We tried to get the records from the various military hospitals. It was a little challenging, but certainly, sure enough, age 31, again, more varicosities, more aching, phlebitis episodes, and he was getting some aching and nocturnal cramps at this point. And he was there with his wife to see me, what are we going to do about this? So he was otherwise fairly fit and well, and his mother had a history of varicose veins, and on exam, he was a muscular man, well-built. He had large clusters of varicose veins that, as you can see in this diagram here, were predominantly anterolateral thighs on both sides, not so much lower legs, and fairly symmetrical, and around the ankles, not a lot of venous stasis changes. So I suggested that he wear his compression stockings more often and to repeat a reflux study. But a question for you in the audience and the panel: what else would you do at this point for this patient? Any other suggestions? Go ahead and shout it out. Pelvic imaging. Okay, I see a few nods. So here is the reflux study, and I just wanted to show you very briefly, I'll try to use the pointer, that he did have an ablated, let's see, do I point it there, or it doesn't work? Okay, thank you, no problem. So on the right side, his proximal great saphenous vein is occluded. Distally, it's still patent, but it only has focal reflux. On the left, some more of the great saphenous vein is occluded, and distally, again, patent, but with focal reflux. He does not have deep or perforator reflux. He has left junctional reflux, and then he has these tributaries that you can see above. They were labeled on the diagram as anterior accessories. They're really outside the fascia, so I call them tributaries. They're large, they're refluxing, and particularly on the left side, you can see they're feeding areas of varicosity where there was evidence of prior phlebitis. So that's what we have. And, of course, here we have someone with multiple incidences of varicose vein recurrence, and in the studies, the recurrence can be around 1 in 5 cases, and in the ablation trials, they cite things such as GSV recanalization or accessories, other reflux as a potential cause. But these studies do not look routinely at the iliocaval system. So what are we going to do for this patient now? I did end up getting an MRV, partly to look for fistulae, but partly to look at any evidence of pelvic disease. And on the right is just an anatomic illustration for you. And the patient was reported to have a classic MAY-THURNER compression at the left common iliac vein, but also had bilateral external iliac vein compression against the adjacent arteries and the psoas muscle. Here are some more images. I don't have a pointer, I apologize, but you can see the iliac arteries are compressing the vein on the left, and perhaps you might be able to appreciate compression of the right external iliac vein in some of these images as well. So I did go ahead, for better or worse, and perform deep vein studies. We perform IVUS, and I'm sorry it doesn't play entirely well, but it did confirm it was in line with the findings of the MRV, that there was a classic MAY-THURNER and bilateral external iliac vein compressions. And in this setting, I did actually decide to go ahead and stent those compression points. I happened to use the Aubrey stents, and we IVUSed them. We had a good lumen gain, and the procedure was uneventful. And then, and only then, I referred him for ambulatory phlebectomy to the varicosities that remained. And it's only been short-term follow-up, but so far he's done well, but of course, long-term, we shall see. So what about evidence for what I did? And of course, this really follows very nicely from the last excellent talk, that really what I'm doing is not evidence-based, is purely based on conjecture. There is, I'll go back, see if I can show you one more, seems not to show me. Well, there is, this will be the last slide. So Neglen and Rogers' group did publish some data in the prior decade where they looked at more advanced disease patients where iliac vein stenting was done at the same time as elimination of the saphenous vein with surgery or with ablation. And in their study, they found that the ambulatory venous pressures and reflux measures were better afterwards, but there was no meaningful control group. There was no group where they only did one modality. So really, there's no data for this, and this was purely based on conjecture, and I'd be grateful for the panel and the group's comments on this approach and whether they would have done things differently. Thank you for your attention.
All right, thank you. That was outstanding. So we're going to have to skip our panel discussion. We're a little bit behind on time. Please hold your questions. We do have 2 more opportunities, and we'll ask the speakers to stay up after our session is over. So our next speaker is Matt Cavender. Do we have a Matt Cavender? Okay. We will set out an APB for Matt Cavender, and then we'll skip on ahead to Mohammed Ansari. This is not good. Do we want to have a panel discussion? Okay, well then we will, why don't you do a panel discussion?
Okay, sounds good. Okay. All right. Hey, you get a phone call. So let me start with Karim. That's a good analysis that you're doing, Karim, and the number that caught my attention was the number of males, the proportion of males that are getting stented. So what are your thoughts on it? And what you talked a lot about your project. What are your goals with this? Is this a descriptive study, or what are you planning to get out of it?
Yeah, so, well, thanks for that question. For me, when I tried to find a way to answer this question, my feeling behind, my bias, I guess, if you would, was, are we seeing, now with the advent of FDA stent approval, are we seeing a similar pattern and trend to what we saw when endovenous ablation occurred? And what we need pause to really critically think about, who are the patients we're putting them in. We need to hone in early on the appropriateness for these stents before, we get patients into trouble, we get ourselves into trouble. And so in finding this database, I wanted to see what were trends in access to venous stenting, who were the patients that were getting it, what were the indications. And a lot of these are based on ICD-10 codes, which are not perfect, not precise, but maybe you don't know how to code. I mean, there's all kinds of things that can bias that distribution. And then also try to see if there's a way to regionalize where these procedures are most, the largest proportion are located across the country. I think amongst those of us who do a lot of endovenous work, we hear murmurings of, oh, there's more or too much in one location versus other. And also to see, what were potential outcome variables that we could look at based on this. And so for me, it was really understanding the trends and the trends in relationship to the FDA recalls.
Got it. And did they include all hospital-based and OBL?
So these were just hospital-based.
Okay, got it.
So
Okay.
they're referral-based hospitals, not OBLs. So that was not part of this group. One of the things we saw is that really around the time points, when we work it down to 3 time points, what we're seeing is that there's really not a pause or a change, and if anything, the numbers continue to rise. We couldn't see what stents were particularly, what stents were being used, but what we're noticing is that there's definitely a discrepancy with, I think, what we think of the trends in, which patients have venous disease, and that doesn't correlate with who's getting venous stenting. We looked at race, and so white men versus African American men, and we're noticing that the pattern of outcomes and survival are worse for African American men. And most of these patients are, the thrombotic patients. We can't look at, based on our limited data, we can't look at, patency or outcomes or reintervention, so that's a little challenging to understand. And then to me also, the pelvic congestion group brings a bit of thought, because I think that's one group that's even more controversial, or like, what are the best therapies for those patients? So that's kind of where we're at with the data, and really just an understanding on a national level, because it's US data, what we can learn and what we could talk about to bring pause and not try to avoid, what we saw with endovenous ablation.
Great. Next is Dr. Giri, and then Dr. Nazal have a comment.
Yeah, I actually just wanted to follow up. Thanks for doing this super important work. One question I had both for Carmen and Robert, I can imagine that the other side of some folks, what they're thinking maybe when we're worried about some overuse here has been brought up. They're thinking, okay, I've got IVUS. This is, a non-obstructive lesion. It's a kind of a relatively normal vessel. I've got dedicated venous stents. I know how to put them in. And what they're saying is, so what's really the harm? And I don't know if you might be able to clarify for the crowd, either one of you, what you're concerned about, what you've seen, what the percentages are in some of the studies. I think that would be super helpful for people to hear, given that we have 2 experts here on this.
Yeah, I think the group is, the message today is really the symptoms, and the patient should drive the therapy. And so if you're placing, I think for me, and again, a NIVL, non-thrombotic patient, I think what's the harm? Well, these are young patients. You have to follow these stents for life. They have about 50 years left of their life, at least, ahead of them. And I think we're still learning about what the optimal medical management is for these patients. Do we just do antiplatelets? Do we do nothing? Do we do a short period of anticoagulation? There's all questions that are unanswered. And I think what's most unsettling to me when I get someone afterwards with a stent as a second opinion is they've not even undergone the core of venous insufficiency workup, which is a venous insufficiency scan. They haven't undergone just looking at the axial system. And so I think really we need to start with an evaluation based on presentation, the symptoms, and start with what we know works and what we have good data on.
So I have a comment and a question. The comment is, we've been dealing with venous disease for decades, actually. And as you can see that we don't understand anything about venous disease. And we keep changing. I actually worked with Dr. Eklof and Peter Niglin on the venous disease, many projects. We were doing surgeries on them. There are also surgeries on chronic venous disease. When you look inside the vein, you say there's no way on earth it will work. We put a stent, we think everything is open. My problem in understanding venous disease, we are racing to do ablation for a lot of veins. We are really getting rid of all resources of bypasses in the future. When we don't understand when there is patency, does it mean normal function? We don't know it actually. If we look at patent stent, does that mean it's a normal function already? It's not the artery that it will supply distally. The other thing we ignore when we open the vein, what is the flow? Is it a low flow or high flow? We have people talking about it should be a high flow, how you decide on the flow. The ultrasound is a poor way of dividing on the flow, and the flow meters, very poor way of doing the flow. So the question is, as long as we are paid for stenting, we will keep doing stenting. The only way to stop really overdoing stenting, to have very strict indications. I am sued now because I did not stent a patient. Somebody else told the patient he should have been stented. My last comment, IVUS is a good tool, but is a problem tool. I usually make 3 measurements. None of them is equal to the other. And then I take the average. say this is the average. So these are my comments. The question is, are we moving from physiology to imaging? If we are doing that, we are not doing a favor to the patient. I want to know what's the opinion of the panel.
I agree completely that we don't have good physiologic metrics for venous system, nor do we have good anatomic. Whether it's post-thrombectomy, clot burden, we still use venographic assessments of, yes, there is clot there. It could be a tiny speck in the external iliac vein, or, there's nothing percentage-wise. Okay, you run a thrombectomy device, you have achieved X amount of success. You don't have that, even with the IVUS technology. So we're lagging way behind. We have to learn a lot, and at some point, we'll stop destroying these veins and try to restore them, right?
I echo what Dr. Harth and Razavi were saying, is that we really don't know who benefits from venous stenting, really. Even in the video trial that you guys are familiar with, they looked at cutoff criteria. For example, for stenosis, they ended up with 64%. But regardless, in the video trial, from the patients who did get venous stenting, and these are C4, C6 type of patients, only 40% had a meaningful improvement in symptoms at follow-up. 20% were no better or worse. So we really don't know how to treat post-thrombotic stenosis. We don't have targets of treatment. We know about all these inflammatory markers that are expressed, but don't know how to target them.
Question from the audience?